Welcome back to part 2 of the SIBO Doctor podcast, and let's jump right back into it. Okay, so that's sort of another good segue to talk about. Before we talk about how would you identify it, let's talk about the different types of stool testing that's available. And I've already kind of given a little teaser on this topic in my previous podcast about different stool tests. So we have your basic culture, we have a PCR test, and we have this metagenomics test called like shotgun metagenomics. Can you just briefly differentiate between these tests?
So you're exactly right. And that's one thing, I'm not sure about yourself, but when I was going through my undergrad degree, there was no training at all or no education when it comes around to sequencing the microbiome. It was basically your patient has dysbiosis, give them a probiotic. That was almost the extent of microbiome training. But when you actually dive deep into the literature, you actually get an understanding that depending on the method used to measure and sequence the bacteria will actually determine the results and what you can do with the results. So as you alluded to, we've got a number of different methods. We have culture, we have a 16S PCR, and then we have metagenomics. Now, PCR, a lot of people would be familiar with this term, given it's commonly described on the news to identify a virus, especially the COVID virus. The PCR is based on testing and probing for particular bacteria. So you've got 16S sequencing, which uses PCR to amplify a particular region of the DNA. I like to give the example of a jungle. Okay, so hypothetically, you're on a safari in Africa and the tour guide says, we're on the hunt for an elephant. So all you're looking for is an elephant. You've got your goggles on, you're looking for an elephant, and straight ahead, you have an elephant. Fantastic. That is PCR because we're actually trying to identify that one particular species or genus level. Whereas if you're looking at other realms, such as metagenomics, it's almost like you're going on this safari and it's like, well, let's see and let's count everything that we can actually possibly see. So we've got butterflies and birds and lions and elephants as well. So we're not just focused on the elephant, whereas metagenomics, we can see a much larger variety because we're not governed by the technology, which is basically just a probe where it's like, do you have this? Yes or no? How much of that? And giving out a quantity. So the other method that's becoming more accessible is metagenomics. Now, to put this into perspective, metagenomics has actually only been accessible to clinicians only in about the last 5 years. So before that, it was only used in research. It's only very recently been able to be utilized by clinicians and patients themselves. In this method, DNA is extracted and through the sample and sequenced. Now, it does this by almost, as the name describes, shotgun. It breaks it up and then through a variety of different methods, able to sequence and understand, well, who does this line of bacteria belong to? Which bacteria does this belong to? Fantastic, we can group it there. Now, by sequencing the DNA in the sample, this method not only tells us who is there, but it's able to tell us what they're able to produce. So we know that different proteins are released or formulated from DNA. And that's the same thing with bacteria. So depending on their food and their fuel source, and depending on their genetic makeup, they can produce things such as butyrate, or they can produce other functional markers such as LPS, purely based on their genetic makeup. So if you were to compare the two frequently used methods, let's say here in Australia and abroad, you've got 16S, which sequences using PCR, whereas you've got metagenomics, which can actually identify, and I think the last count, up to about 6,000 different species of bacteria. So the take-home message here is 16S PCR can identify, let's say, the genus level of bacteria, and it can only identify what it's set out to look for. But with metagenomics, you can actually take a step back and look at a larger number of species, almost all the species, and actually understand what they have the capacity of doing. And so what's more important to remember here is it's function over genus or function over species. So when I say function, that is, what does the microbiome or what does that particular bacteria have the capacity of producing? Is it a good guy or is it a bad guy? Or are we just unsure whether or not it fits under the good, bad category? And the best way to look at that is to go, well, what does this bacteria do and what does it produce? I mentor a lot of newly graduated naturopaths and nutritionists. And I'll give you an example here on why metagenomics in the coming years is becoming more frequently utilized. My example I'll give you is if I was to place a list of 100 different species in front of a newly graduated naturopath, nutritionist, or even functional medicine practitioner, I would guarantee that they would look at this list of species and there would be limited clinical utility with what they could actually do with that. Whereas if you were to actually provide them with this is what the microbiome has the potential of doing. It has the potential to produce butyrate. They would go, this is a beneficial thing. I understand this. Let's support this pathway, which may then, of course, go on to support with intestinal permeability. But it's interesting whereby the depth and the amount of information that we can gather is significantly more. So another example I can give you is in most people, you'll generally have around that 150 different species of bacteria, and that's coming from 6,000 different species that they could have. Now, I had a patient just 2 or 3 weeks ago, and I was looking at their metagenomic microbiome, and they actually had 270 species. Now, that's a huge amount, and that is absolutely fantastic. Their diversity was excellent. I compare this to a patient I had probably about a year ago now who had inflammatory bowel disease, Crohn's disease, ulcerative colitis, and was on long-term antibiotics. And using metagenomics, I could actually see that this particular patient only had 22 species of bacteria in their gut, which when you take a step back and just look at that, it provides a lot more clinically useful information to say, well, this patient with 22 species, even if you know minimal about the microbiome, you can generally say, well, hold on, we need to do a lot of work here when it comes around to gut health, where the patient that has 270 species, and the vast majority of those were beneficial, there's less work to be done there. And so it's just fascinating the depth of information that you can gather when looking at the whole microbiome.
So I have a question about that because, first of all, I want to clarify to the listeners that we're talking about stool testing, which means that you will get information about your microbiome that resides in the large intestine. You won't get any information from a stool test about the diversity in your small intestine or if you have SIBO or any of those things, because that's just not possible with a stool test. And also, so if there are over 6,000 species or, or the potential is there. 250 still doesn't sound like a whole lot. I mean, I get what you're saying, but what are we getting closer to reporting more than just a few hundred? Are we able to, the lab that you work for, is it possible to, is it coming soon that we continue to increase our species information and maybe are able to identify it? Because if you're saying that this shotgun is able to basically record everything that's there, then 250 species still doesn't sound like a lot.
It doesn't actually sound like a lot, but when you look at that, there's a let's say a database of 6,000 species that could be in your gut. I would that's almost a fantastic question. I'd love to know what would happen if you put all 6,000 species into someone's gut. Would that actually be a good thing? Or would that actually be a bad thing?
No, I think it was like you remember that study that was done on, I think it was the Hazda tribe, and they're, basically disappearing old species that have always lived with us are sort of disappearing in terms of species of bacteria. And because of our more sterile environments and our food supply and antibiotics, we're actually killing out these ancient or killing off these ancient species. And the study, I think it was, I can't remember exactly when, but it was a pretty famous study that looked at the diversity of people that had a very minimal contact with so-called civilization. And they had an incredible abundance of bacteria, so it makes sense that you would also require a lot more diversity when you live a lifestyle like that. But anyways, I just wondered if what we're seeing is sort of a species loss that's not just macrocosm but also microcosm, and I think we're seeing that. I certainly see a lot more microbiome issues in my practice than I did 20 years ago. But you're right, our ability to diagnose that was much more limited because the Human Microbiome Project hadn't really been initiated at that point. We were not even on the human genomic project was also not completed when I was going through school. So there's all this stuff that we are learning about the genes of bacteria are actually, this is where we talk about what is your microbiome, what's the ability, what is it producing, and what is it doing for us? Because that's really where I think the mystery still is unfolding of how are these organisms connecting to us and how are they communicating with us and what are they doing for us?
And it's interesting, we look at 150 species and we're like, oh, that's not a lot. But if we actually take a step back to 10 years ago, the level of microbiome sequencing that you could get in clinical practice, it would basically be, you've got lactobacillus species, you've got bifidobacterium species, one or two pathogens, it'd be less than 20 genus level organisms that testing facilities had the capacity to do. So this is actually a huge jump forward to be able to say, well, hold on, we can actually identify down to a relative abundance of about 0.001%, which is a very, very, very small amount. And maybe what you just said there in relation to these smaller quantities of bacteria, they could be dying out, whether it is through the exposure of glyphosates or whether it's through our diet, reducing the type of diversity in our diet and then thereby the fuel sources for many of these bacteria.
And antibiotics that are in our food supply even. So, I think we're both agreeing. It's just always so fascinating to me that we're discovering so much about the microbiome and we're seeing its decline. It's almost like we're exploring the rainforest while we're seeing it being chopped down, So it's interesting.
It's fantastic. When I measured my microbiome probably about 6 or 12 months ago, and this is someone I've never taken antibiotics. I've been vegetarian my whole life. I grew up on a farm. Like I've got everything going. I was breastfed. I was born vaginally. Probably too much information for the listeners, but to look at the species and to look at the number, I had around that 200 mark. And so that's somebody who's almost ticked all these boxes, no diseases, exposed to nature. And from that perspective of, oh, wow, okay, that's actually a substantial amount of bacteria.
Okay, that's like, so the benchmark is I think I did it, when I did that workshop with, I did a workshop a while ago, many years ago with Dr. Horolak. And I kind of won the prize for species diversity. So we should have a species diversity, like a microbiome show off. That'd be cool.
Sounds wonderful.
I know. I was like, okay, I should just probably package and sell my poo for FMT. So, but anyways, it made me feel good because I also, have a very pristine diet, some would say, and that goes a long way. Okay, let's move on to. We talked about that microbiome imbalances can induce intestinal permeability. So, what are some of these markers that we're looking out for if we're considering that the microbiome has induced somebody's intestinal permeability?
So generally speaking, when I look at a report in my clinical practice, there's five major markers that I'm looking out for. The first of which is the capacity of the microbiome to produce Hexalps LPS, whether or not there's any Befragilis toxin producing bacteria, hydrogen sulfide producing bacteria, and then you've got your good guys, which are your Butyrate producing bacteria and your IPA producing bacteria. So IPA stands for 3-indole propionic acid. And maybe if you'd like, I can dive into each of these in a bit more detail.
Yeah, sure.
So starting off with, let's not be biased here, but my favorite marker when it comes around to looking at intestinal permeability, especially when it's induced by the microbiome, and that is Hexalps LPS. So in vitro and animal studies actually have indicated that Hexalps LPS increases intestinal permeability through the activation of the immune receptor TLR4. Okay, so most clinicians would actually be aware of LPS, but many would be for the very first time going, well, hold on, what's this hexa that you're putting, in front of LPS? LPS in itself can be broken down into many different subgroups. You've got penta, tetra, hexa. It all depends on the makeup of the of the LPS. Now, what the research is actually indicating is that it's actually the hexa LPS, which is the most pro-inflammatory of all the other LPSs. So many different bacteria have the capacity of producing or releasing LPS. And it's really interesting to quantify and really look at, well, what does somebody's microbiome, what is their capacity to produce LPS? So I recall one patient, and I alluded to this patient just before, the one with the 22 different species. So lots of antibiotic use, but when looking at his overall microbiome, 80% of his microbiome had the capacity to produce Hexalps LPS. So just think about that for a moment, that 80% of the bacteria in his gut where the E. coli had that capacity to produce LPS. No wonder, he has constant flares in his ulcerative and Crohn's disease. It'd almost be impossible. This is where your magic poop might come in handy, is to do an FMT to actually almost introduce some of these beneficial bacteria. So Hexalps LPS, definitely one to to keep your eye out for when it comes around to identifying if a patient or if you have microbiome-induced intestinal permeability.
Okay, so let me ask you something about that because, I don't know any other lab other than your lab, Microba lab in Brisbane, who checks for Hexa LPS. So what are the bacteria that we know that LPS is produced by gram-negative bacteria, so Klebsiella, Citrobacter, E. coli, and E. coli and Klebsiella are the primary or the dominant bacterial overgrowth in hydrogen-dominant SIBO. So are both of them species that produce this Hexa LPS? Or do we know the exact species that produce this?
That's a very good question. And the ones that you've just mentioned, they are Hexa LPS producing bacteria. So if a lab can actually identify them down to the species, then you can quite confidently say, oh, yes, they are producing Hexa LPS. But my best guess is that there's probably around 30 different species in the gut that have the capacity to produce Hexa LPS.
Okay. And, with Klebsiella, we have several different species of Klebsiella. Are they all producing Hexa LPS?
No, not all Klebsiella species are producing Hexa LPS. It's a very good question. Something I don't know the answer to off the top of my head, but there are a select few of species that can actually produce Hexa LPS.
Okay. So, and what about LPS, right? So lipopolysaccharide is one thing you look out for. So if somebody doesn't have access to your lab and they just do a stool test and they have a preponderance or a real big overgrowth of these what we call pathobionts, right? So these are organisms that are normal at low amounts, but when they overgrow, they pose a threat and they become pathogenic. So you can, if you are listening and you're just sort of a bit lost in the woods from all this techno talk, but basically, if you've had a stool test and you have a huge amount of gram-negative bacteria present, it's not unreasonable to assume that you also have high levels of LPS in as part of your microbiome. So
a lot of labs will do that E. coli, and so E. coli being a Hexa LPS producing bacteria, so that can be a good indicator. But something to consider is because there are so many different species that produce it, you want to collectively go, well, hold on, is it just one species that's producing Hexa LPS, or are there multiple species? So that's really when it comes down to looking at species level microbiome, that is quite interesting.
Okay.
So others I alluded to was Befragilis. So Befragilis toxin, there's been studies to show that this actually impairs intestinal barrier integrity. And it does this by binding onto colonic cells and stimulating the disassembling of tight junction proteins, so resulting in intestinal permeability. So basically, there are some strains of Befragilis that have the capacity to produce this toxin, so Befragilis toxin, and that's the toxin that results in intestinal barrier function and then diarrhea. So, and this is a common species that is measured, and it is got a lot of research out there for linking up with diarrhea.
And it's Bacteroides, right? So Bacteroides fragilis?
Mm-hmm. That's correct. So if a patient presents in my clinical practice with diarrhea, I would actually want to go, well, hold on. Yes, there's multiple different causes for diarrhea, but is Befragilis toxin a contributing factor here? And exactly what you've alluded to earlier on in the podcast is that loose stools is a clinical symptom of intestinal permeability, and it could be that through the Befragilis toxin.
And not many labs test specifically for that. So let's move on. But it's great. It's good to know. I think I've only ever had one person have this, so I'm not sure how common it is. But it is a good marker to keep an eye out. What about the hydrogen sulfide? We know that high levels of hydrogen sulfide certainly causes a lot of gut inflammation. So,
Yes. Yes.
one of the interesting evolution of us having in terms of experts I've talked to also is the evolution of our understanding of hydrogen sulfide producers. And we used to just think Desulfovibrio and Bilophila species. And now we understand that other species can upregulate the hydrogen sulfide production, which is a curiosity to me. Like, under what circumstances, are other species driven to produce hydrogen sulfide?
It comes around to the fuel source. Now, this is a fascinating one when it comes around to hydrogen sulfide producing bacteria, is that the fuel source or what amino acids they're exposed to in the large intestine and possibly even the small intestine will result in the capacity to produce hydrogen sulfide. And the biggest one here, now this is going to be a huge aha moment, is cysteine. So what the research has shown, and now a lot of this is mechanistic research, is cysteine or the supplemental form NAC, N-acetylcysteine. Those who have bacteria that produce hydrogen sulfide, if they're exposed to cysteine, or if they take a cysteine-based supplement, so NAC, which is a very common supplement in the functional world, that can actually make their production of hydrogen sulfide more severe, thereby resulting in more intestinal inflammation and greater permeability. So it's one thing that I like to, before I prescribe NAC, I'd like to assess someone's microbiome and go, well, hold on, is me giving NAC going to actually cause more harm than good? Now, the vast majority of the time, there's no problems at all, but there are some individuals, and I've had a client who had an adverse reaction to NAC and acetylcysteine, and I actually put it down to that they had too many hydrogen sulfide producing bacteria, and that was actually exacerbating intestinal inflammation and permeability. The other thing to consider here is that in low levels, hydrogen sulfide is protective, but in high levels, it can actually inhibit the uptake of butyrate in the intestines. Now, that almost leads us on to the next marker of microbiome-induced permeability, and that's butyrate. And it's almost one of these things where you want to take those hydrogen sulfide-producing bacteria in combination with someone's butyrate. So we know, and butyrate is probably one of these metabolites, these markers that is probably the most researched out of all of them. And so we know that there's a lot of research. It's protective for colon cancers, and it's protective for intestinal permeability. And it's one of these metabolites that we could talk all day about. But there was research that I actually came across earlier this week, and it was a study published in Diabetes, and the title was along the lines of butyrate producing bacteria and insulin homeostasis. And it was this amazing longitudinal study that used metagenomic studies and actually looked at participants' ability to produce butyrate. Now, the study assessed different butyrate pathways and insulin markers, so fasting glucose, insulin resistance, and so on. And what they actually showed was there was about 10 butyrate-producing bacteria that were associated with a beneficial outcome for insulin resistance and fasting insulin. So the reason I thought that this research is quite fascinating is because in 2019, my own research, we actually came out and kind of shocked the intestinal permeability world a little bit. And we said that intestinal permeability is very closely linked with metabolic conditions. So I'm just speculating here, okay? And this is my educated opinion, is that I wonder whether or not the link between intestinal permeability and metabolic conditions is actually governed by the microbiome, and in particular, their capacity to produce butyrate.
Yeah, pretty
interesting.
Cool. Yes, very interesting. And I mean, for the listener, butyrate or butyric acid is one of the three main short chain fatty acids that are often measured on a stool test. And butyrate has a lot of benefits, including energy production, anti-inflammation, even motility in the digestive
Hmm.
tract.
That is
And there
correct.
are a number of key species who produce this, including Faecalibacterium Prosnitzii and a host of other bacteria. So, but this is a fascinating connection to blood sugar, really regulation. And would you also think that it has some role in hypoglycemia, not just through insulin, but because we do see a lot of people with hypoglycemia that also have microbiome disorders.
Yeah.
Hypo. So like these are like
Hypo.
reactive
Hmm.
hypoglycemia,
Hmm.
and anything that if you came across that in your research as
Yes.
well.
So that same study actually identified two other species which were butyrate producers that were actually associated with hypoglycemia. And I thought, oh, that's interesting. They just kind of alluded to it. They didn't discuss it in too much detail because it's a new area of research. But I wonder there as well if it could go the other way when it comes around to regulating blood glucose. But
Now, and
yes,
did you have another marker that you or marker?
the last marker is IPA. Now this is
Oh yes,
so.
IPA. This is not India Pale Ale microbrew, but
I wish it would make life a little wonderful, but no, it
yes.
isn't IPA the drink. It is 3-indole propionic acid. I like to shorten it to IPA because that's a bit of a mouthful. Now, the beauty of this one is it's a beneficial. So a lot of what we've touched on have been detrimental, excluding butyrate, of course. But when it comes around to IPA, the research is actually suggesting that it has it's a beneficial antioxidant, and it actually has a role in glucose regulation, inflammation, and maintaining intestinal barrier function. Now, this is where it gets really interesting. Is that low levels of IPA? So there's only a few bacteria. So the last time I counted, there's probably about 15 species of bacteria that actually have the capacity to produce IPA. And some of these, their name is like CG83, very bizarre
Mhm.
um, species. But how this actually works is these species that have the capacity to produce IPA, they do that through the breakdown of tryptophan. And so when they break down tryptophan, the IPA enters into the bloodstream. Now, there was some fascinating research that came out in 2020 from Yang. Now, this was an RCT trial out of the USA. And basically, they did an intervention of a particular pomegranate juice called Pom Wonderful. Now, this pomegranate juice, it had a polyphenol in it called allergic acid. Okay. And what they actually found was participants that consumed this for a year, it actually maintained their plasma IPA levels compared to a decrease seen in control. And so when it comes around to microbiome induced permeability, IPA is something, it's a protective factor and something we actually want to increase. And it almost appears that the number one factor to increase it would be allergic acid.
Hmm. And no other polyphenols or like nothing else works quite like that, or
There
I mean,
is,
surely there are other foods that are that are microbiome supportive, like in usually plant-based is, plant-based foods. One of the reasons we love them so much is not just because of the fiber content, but also because of the
mhm.
polyphenols and other phytochemicals that really seem to communicate. And I mean, plants or bacteria, our microbiome loves plants, right? And so I'm sure that if we come across something else, we'll find something else other than just because pomegranate juice is this not that easy to find, so surely there's got to be other foods.
So it's not just the pomegranate. So the research actually put it down to consuming 120 milligrams of allergic acid. Now, if we actually, put on our research hat, we can find other foods that have around 120 milligrams of allergic acid. And the number one would be chestnuts. So you can get these amazing chestnuts from Costco, absolutely to die for. And if you do some maths, it's about 15 grams of chestnuts that someone would need to eat.
That's like one chestnut or something, right?
It's not. It's 2 or 3 chestnuts. It's a very small amount. The other big one is blackberries. So a punnet of blackberries actually have enough allergic acid to actually have that prebiotic action to support IPA production and then thereby intestinal permeability.
Great. And it also, I think all those foods also support Acromancia, or at least a few of those foods. That's great. I mean, look, I could talk to you for hours because this kind of microbiome nerding out is I love that kind of stuff, but we are nearing the end, or we're at the end of the podcast. So before we wrap it up, I wanted to kind of see, the wonderful thing is that you're a practitioner and a researcher. So, what are some of the clinical pearls that you can share with us of how you treat intestinal permeability?
When it comes around to intestinal permeability, my biggest advice to the listeners is identify the subgroup, determine whether or not it's alcohol-induced or microbiome-induced or exercise-induced. Once you have that information, then create targeted therapies to address that subgroup. So given that we're on the topic of microbiome-induced intestinal permeability, there's 3 major things that you could consider when it comes around to supporting microbiome-induced permeability. And that would be considering the whole microbiome, the use of targeted treatment interventions, and then what I just mentioned previously of the allergic acid. So when I refer to the whole microbiome, I'm referring to fiber, really emphasizing the importance of fiber, supporting that whole gastrointestinal health coming down to inflammation, digestive secretions, peristalsis, and so on. When I refer to the targeted treatment interventions, especially for microbiome-induced permeability, is really understanding what the microbiome is doing. So, for example, if somebody has high Hexalps LPS, and that's driving somebody's intestinal permeability, there's research to suggest that GOS at about 4 grams per day is beneficial when it comes around to reducing LPS-producing bacteria.
So GOS stands for galacto-oligosaccharides, for those of you who are listening. And that's a prebiotic powder. If you're in the UK, we usually recommend Bimmuno. If you're in Australia, there are distributors that sell GOS. Just for those of you listening. In America, I think I don't actually know who makes it over there, but Bimmuno is sort of like a very well-known brand and of GOS. So GOS is a good one for LPS.
And it's one of the only things that has been shown to actually not just reduce serum LPS, but reduce the bacteria that have the capacity to produce LPS. So the patient I was alluding to earlier with 22 species and high amounts of LPS, giving GOS can go on to help with that patient's presentation, because it potentially has that capacity to bring down those pathogenic LPS producing species.
Great. That's a really good tip. Fantastic. Anything else? What about the old glutamine and zinc and the typical stuff that we do? Do you use a lot of that?
When it's not microbiome-induced permeability, then yes. So exercise-induced or stress-induced, then that's when I'd bring out glutamine at 5 grams 3 times a day, that's when I'd utilize glutamine. The other big one is Saccharomyces boulardii. In my own PhD, that had a high level of evidence to support with intestinal permeability. Other big ones would be zinc. We can't go past zinc and its clinical utility, not just to support with intestinal permeability, but to support with digestive secretions and wound healing. And it's such an important mineral.
Fantastic. Gosh, I'm sorry, but we have to kind of wrap it up. But it's been really amazing to talk to you. And, where can people find you? I know you're probably too busy to take on more patients, but I always want to promote people that are in practice. So do you, or also, your lab? I know that I don't normally mention or promote labs or companies on this podcast, but I like Microba. I like what you're doing up there. So do you want to just give us a bit more information about where people can find you?
Yeah, definitely. Well, if there's patients, I see patients, and I do a lot of mentoring with practitioners. You can find more information on my website, bradleech.com. And if you want to know more about Microba and Microba testing, then you can visit Microba's website and gather a bit more information on measuring the whole microbiome.
Right. Okay. We have all that information in the show notes. And Dr. Leech, I'm so glad I get to say that. You finally completed your PhD. A huge congratulations to you on all this work that you're doing. It's been an absolute pleasure to have you on the podcast. I'm sure that I'll invite you again for further diving into our favorite topic, the microbiome.
Nirala, it's been a pleasure, and absolutely love chatting with you.
Thank you for listening to the SIBO Doctor podcast. We hope you find the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering. Thanks again for listening.